Yeah, so the purpose of my study is to look at the relationships between subjective cognitive difficulties and objective cognitive performance during the interictal phase. A lot of patients report cognitive difficulties during that prodromal period. There's a lot of research that's been coming out in recent years about prodromal cognitive symptoms. However, there's a lot of inconsistent research regarding objective cognitive performance during that interictal period. So I want to look at the association between those two things. And what we found is that there are significant associations between prodromal word finding difficulty in patients with migraine and objective cognitive performance during that interictal period. So when patients report word finding difficulties, typically they describe problems with finding that exact word that they want to use, like that tip of the tongue problem. Or they may know what they want to convey, but they just have trouble forming those words to express their thoughts. And these are symptoms that have been described in prior research in people with migraine during that prodromal phase. Now, when people describe concentration difficulties, they may describe issues with sustaining their attention or maintaining their focus. So for example, let's say they're reading a book and they just find themselves reading that same paragraph over and over again. Or even that same sentence over and over again. We'll hear that sometimes. Or maybe they're having a conversation with someone and they're physically there, but they're not really there. They may be zoning out or they get distracted really easily. And so if patients are experiencing problems with word finding or concentration difficulties, it's important to explore these symptoms further, not just by asking them what the difficulties are, but knowing, when these difficulties tend to happen and also how it's impacting their functioning day to day. Because once we have that information, that's going to help guide our assessment and really highlight which cognitive areas warrant closer attention. So some patients with migraine report difficulties with their cognition during that interictal phase. Now, when we do a cognitive evaluation, we need to pay very close attention to both their subjective cognitive symptoms and also their objective cognitive performance. And we focus on multiple domains. So that will include attention, speed of processing, executive functioning, language, visuospatial abilities, and memory. And it's important to align their subjective experience with the objective cognitive performance, because that's really going to help build a complete clinical picture. I recently had a patient who just came in with memory problems, and they asked me, why are we doing all this, right? There's so many areas that you're looking at clearly. And so just to provide an example, if a patient does come in with those memory problems, what we sometimes see on exam is that they're having issues, or we see weaknesses in other areas of cognitive functioning, such as attention or executive functioning, and that's impacting their memory and therefore contributing to their memory concerns. And so, if they're having a conversation with someone and they're not really paying very close attention, then later on they may say, I completely forgot what they said in that conversation. But really, they didn't really fully process what was said in the first place. So that kind of information that we get from the cognitive exam and aligning their subjective experience with the cognitive exam can really help guide our interpretation and also allow us to provide more tailored recommendations. So when patients are reporting cognitive disruptions between their migraine attacks, it's important for us to recognize that these symptoms may be part of that broader migraine experience. It's not just limited to their head pain. And so once we have an understanding of their cognitive difficulties, and also we understand the nature and the extent of these cognitive difficulties, then we can start thinking about management. Now, management doesn't always mean a formal intervention. It can mean providing compensatory cognitive strategies. For some patients that may mean organizational strategies, or maybe adjusting task demands when they feel really they're not at their best cognitively. And so really the goal is to provide practical recommendations for them. It needs to be more patient-centered. It's not a one-size-fit-all. We can't just provide the same recommendation to every single patient. That's not going to work. Like I said before, we need to tailor those recommendations according to what the patient needs and also what really matters most to them.